and a chest X-ray should be done as soon as possible to verify placement. Once the balloon is positioned in the descending thoracic aorta, the catheter is attached to the pump console. It is time to inflate and deflate in concert with the mechanical cardiac cycle. The primary goal of counterpulsation therapy is to restore and maintain a balance between myocardial oxygen supply and demand. Inflation of the intra-aortic balloon at the beginning of diastole increases myocardial oxygen supply. As the balloon deflates just prior to systole, afterload is reduced, lowering myocardial oxygen demand. When the balloon inflates during diastole, the left ventricle is relaxed and the coronary arteries are filling with oxygenated blood. Balloon inflation displaces blood back to the coronary arteries to improve myocardial oxygen supply and increase aortic diastolic pressure. This effect is referred to as diastolic augmentation. The intra-aortic balloon deflates just prior to left ventricular ejection. With rapid deflation of the intra-aortic balloon, the end diastolic pressure in the aorta is reduced. This reduction in pressure decreases the resistance against which the ventricle has to work. Subsequently, the systolic wall tension, or afterload of the ventricle, is also reduced. These effects result in a decrease in myocardial oxygen demand and are reflected by a reduction in aortic end diastolic pressure and the subsequent systolic pressure. When a patient is being supported with intra-aortic balloon counterpulsation, ideally, both the electrocardiogram and arterial pressure waveform are monitored on the pump console. These signals enable the pump to identify the phases of the patient's cardiac cycle. The clinician can use these waveforms to assess the effects of therapy. Proper use of the intra-aortic balloon pump requires a thorough knowledge of two important concepts: timing and trigger. Timing refers to the inflation and deflation of the balloon in relation to the patient's cardiac cycle. Timing can be visualized on the arterial pressure waveform. Trigger is the physiologic signal from the patient that identifies the beginning of a new cardiac cycle. An electrocardiogram is the preferred trigger source, since an electrical impulse precedes and initiates the mechanical event. The R wave on the electrocardiogram represents the onset of a new cardiac cycle and is referred to as the trigger event. In circumstances where the electrocardiogram is not available for use as a trigger, the arterial pressure may be used to maintain synchrony with the patient's cardiac cycle. Inflation and deflation of the intra-aortic balloon have a number of primary, secondary, and systemic effects. These parameters should be regularly evaluated to assess the effectiveness of therapy. As previously noted, there are two primary benefits of counterpulsation: increased myocardial oxygen supply with balloon inflation, and decreased oxygen demand with balloon deflation. These benefits are based on volume displacement. The vascular system is a closed system with a relatively fixed volume of blood. As ventricular ejection occurs, the volume of blood in the aorta increases. When an intra-aortic balloon is in place and is timed to inflate at the onset of diastole, the inflated balloon displaces that blood volume, increasing perfusion to the coronary arteries. Inflation of the balloon will also raise systemic pressure in diastole, an effect known as diastolic augmentation. The intra-aortic balloon remains inflated throughout diastole to maintain this volume displacement. The balloon is timed to deflate just prior to left ventricular ejection. With rapid deflation, the pressure in the aorta is reduced. This reduction in pressure decreases the resistance against which the ventricle has to work. Subsequently, the systolic wall tension, or afterload of the ventricle, is also reduced. The reduction in pressure makes it easier for the heart to empty, potentially increasing cardiac output. These effects are reflected by a reduction in aortic end diastolic pressure and the subsequent systolic pressure. In summary, the secondary effects of counterpulsation are likely to include any of the following: improved cardiac output, decreased heart rate, reduced pulmonary artery diastolic pressure and pulmonary capillary wedge pressure, reduced systemic vascular resistance, decreased systolic and end diastolic pressures, diastolic augmentation in early diastole, increased mean arterial pressure. The systemic effects of intra-aortic balloon counterpulsation can be assessed in the nervous, renal, vascular, and respiratory systems. Improvement in cerebral perfusion enhances the patient's level of consciousness. Urine output increases due to improved renal perfusion. The increase in cardiac output augments peripheral perfusion and may be evidenced by skin that is warm and pink. And, as cardiac output increases, respiratory status improves. Assessing the arterial pressure waveform, the hallmarks of optimal timing include the following: sharp V at the dicrotic notch, followed by an increase in the diastolic pressure. Diastolic augmentation that is ideally suprasystolic. Reduced aortic end diastolic pressure, which is referred to as assisted end diastolic pressure. Reduction in the subsequent systolic pressure, which is referred to as assisted systole. An increase in the mean arterial pressure. The balloon may be set to inflate at different frequencies: 1 to 1, 1 to 2, or 1 to 3. At the 1 to 1 frequency, the balloon inflates and deflates with every cardiac cycle, providing full support to the patient. Each systole and diastole is assisted, and augmentation is achieved with every cardiac cycle. At the 1 to 2 frequency, the intra-aortic balloon inflates and deflates once every other cardiac cycle. At the 1 to 3 frequency, the intra-aortic balloon inflates and deflates once every third cardiac cycle. This frequency is most often used when a patient is being weaned from counterpulsation support. When assessing an arterial pressure waveform at the 1 to 2 or 1 to 3 frequencies, some of the pressures are assisted and some are unassisted. For instance, at the 1 to 2 frequency, if there is a normal dicrotic notch present and the diastolic pressure decreases, there is no benefit from balloon inflation, and therefore no diastolic augmentation. The next end diastolic pressure is unassisted, and the next systole is unassisted. If instead of the normal dicrotic notch there is a sharp V followed by a rise in the diastolic pressure, the balloon has inflated, creating diastolic augmentation, which will be followed by assisted end diastolic pressure, then assisted systolic pressure as a result of balloon deflation. The assisted pressures are ideally lower than the unassisted pressures as a result of the afterload reduction that has occurred. Ideally, the augmented diastolic pressure will be suprasystolic, or higher than the patient's systolic pressure.